Welcome everyone to the 71st Annual Alfred A. Strauss Lecture. And I'll start by introducing Dr. Paul Ramsey, Dean of the UW School of Medicine and Chief Executive Officer of UW Medicine. Dr. Ramsey, a few words to introduce this important lecture.
Thank you very much, Dr. Wood. Good afternoon to everyone. I am delighted to be joining you for the 71st Annual Strauss Lecture. This is a tradition that the Strauss Friedlander family has been carrying on for so many years that was begun by Dr. and Mrs. Alfred A. Strauss. Born in Germany in 1881, Dr. Strauss came to Cornwell, Washington at the age of 10. An honor graduate of the University of Washington in 1904 and an outstanding member of the Alumni Association, he received the singular honor of Alumnus Summa Laude Dignitas in 1951. Dr. Strauss was a football and baseball star as an undergraduate. As an alumnus, he was active in the recruitment and establishment of scholarships for athletes at the University of Washington. He personally recruited more than 75 football players from the Chicago area, 5 of whom became college All-Americans. In 1981, Dr. Strauss was elected to the Husky Hall of Fame. Dr. Strauss received his MD at Rush University of Chicago Medical School in 1908, graduating #1 in his class. He interned for 2 years at Michael Reese Hospital in Chicago and completed a brief surgical fellowship under Professor Enderlein in Heidelberg, Germany. He then returned to Chicago, where he spent his entire medical career. Dr. Strauss possessed a rare combination of skill, vision, and drive, and he was ultimately involved with many firsts in the advance of medicine, including refinements of pyloroplasty, subtotal gastrectomy for peptic ulcer disease, surgical advances in inflammatory bowel disease, and the first description of an abdominal wall zipper to facilitate frequent re-explorations. Dr. Strauss and his 2 physician brothers, Herman and Siegfried, also University of Washington undergraduate alumni, founded Weiss Memorial Hospital in 1953 in Chicago. Dr. Alfred Strauss is also very well remembered for his influence in founding the University of Washington School of Medicine. On July 22, 1944, Dr. Strauss, as a member of the proposed medical school committee, met with Governor Langley and strongly advocated for state funding to establish the new University of Washington School of Medicine. An appropriation bill was signed by the governor on March 15, 1945. Soon after, in the fall of 1946, the first class started medical school. True to his continued interest in our institution, Dr. Strauss sponsored a surgical lectureship in 1950 for the Department of Surgery, and these lectures have been a prestigious annual event ever since. Today's program is supported by the Alfred A. Strauss, MD, Endowed Lectureship in Surgery, established by the estate of Mrs. Marjorie Friedlander, daughter of Dr. Strauss, and annually supported by generous contributions from Dr. Strauss's nephew, Dr. John Strauss. We are fortunate to have Dr. John Strauss and John Friedlander, the son of Marjorie Friedlander and grandson of Dr. Alfred Strauss, here with us today. I wish it could be in person, but I welcome you on Zoom. It is a pleasure to honor Dr. Strauss once again at this 71st annual lecture. Thank you.
Thank you very much, Dr. Ramsey. And I want to add my own words of thanks to both Dr. John Strauss and Mr. John Friedlander, who have supported us, have become friends, have become my friends along the way, and are really important for the continuing of this incredible legacy of now 71 years of the Alfred A. Strauss Lecture. And this year also we have a special treat that we have Dr. Strauss's portrait, newly framed and exhibited in the offices in the Department of Surgery. So this is now in a proud location inside the offices of the Department of Surgery. But it's really my distinct pleasure to introduce our Strauss lecturer, Dr. Edward E. Cornwell III. So Dr. Cornwell is the LaSalle de Leffall Junior Professor and Chair of the Department of Surgery at Howard University School of Medicine and the Chief of Surgery at Howard University Medical Center. I think it's worth noting that Dr. Leffall was the 1997 Strauss Visiting Professor, and the title of his talk was Medical Ethics as Seen by a Surgeon. And Dr. John Strauss reminded me of this, and just want to acknowledge that Dr. John Strauss first attended the Strauss lecture in 1960 when he was a freshman at UW, and has been at all of these lectures except for 4 since then. So he's, this is his 57th Strauss lecture. Dr. Strauss, thank you for your loyalty. A little bit more about Dr. Cornwell. He did his surgical training at LA County, USC, his trauma critical care fellowship at Maryland. And then he rose to the academic ranks, first at Howard, then he was recruited back to LA County and USC. And not too long after, he was recruited then to Johns Hopkins and recruited by John Cameron to become the new chief of trauma for a new level 1 trauma center at Johns Hopkins. I think it's interesting to point out that while chief of trauma at Hopkins, Dr. Cornwell became a TV star. He's featured in an ABC television series called Hopkins 24/7, which was a 6-part documentary that followed Dr. Cornwell in the emergency room and in the East Baltimore community. And this is relevant because Dr. Cornwell's interest has been in the culture of violence and trying to change the culture of violence, and his interest in the prevention, treatment, and outcome disparities of traumatic injuries and their critical care sequelae. Interestingly, after the ABC series, there was a lot of attention to his anti-violence message. People magazine, Oprah Winfrey, and he was asked to, Dr. Cornwell was asked to participate in a video starring 50 Cent, otherwise known as 50 Cent, that was going to be anti-violence. But when Dr. Cornwell viewed it, he felt that it was really the opposite. And he said that it seemed to glamorize violence and refused to participate. He quoted, "I told them I was offended by this as a Black male, as a father, and as a trauma surgeon." In 2008, Dr. Cornwell was recruited to Howard to become the chair of the Department of Surgery, where he is today. He's authored or co-authored over 300 articles and chapters, given over 365 invited presentations. This will now be 366, Dr. Cornwell. He's delivered named lectures. He served as president of the Society of Black Academic Surgeons, president of the surgical section of the National Medical Association, and the chairman of TraumaNet of Maryland. He also recently served as secretary of the American College of Surgeons and is on the board of managers of the American Association for the Surgery of Trauma. So Dr. Cornwell has received numerous awards and citations for his efforts, outreach and violence prevention. He's received teaching awards in every faculty position he has held and was selected as the commencement speaker at the USC School of Medicine in 1996 and at the Howard University College of Medicine in 2002, where he also received the Distinguished Alumni Award from Howard University in 2014. So we are really very privileged to have Dr. Cornwell with us today. and speaking on outcomes, disparities in trauma care, who, when, and why. Dr. Cornwell, thank you for joining us.
Well, thank you, Dr. Wood. That on top of all your other skills, I didn't know you had such street cred. I didn't know you knew that 50 Cent story. I'm gonna tell my mother that introduction she wrote went very smoothly. I greatly appreciate the invitation. I appreciate Dr. Strauss, Mr. Friedlander, and their commitment to this lecture, which is truly an honor. Thank you, Dean Ramsey, for you being here. I'm gonna tell my dean some selective facts. I'm gonna tell him I gave a talk at 7 o'clock, after 7 o'clock in the evening on a Friday evening, and the dean where I visited was there in the audience. I won't tell him anything about time zones, but not, at least not immediately. It's been both yesterday and today. No lip service here, just a singular honor to have the opportunity to kind of put the icing on the cake by giving the Strauss lecture, and absolutely to be able to join so many of the surgical leaders, and including my hero, Dr. Leffall, to join with him to share in that honor to give this. I'm going to, and the fellowship that this represents is one of the best things about surgery. Not too long, hopefully we'll all be able to do some of this in person. I don't know if the genie's ever going to be completely back in the bottle. I think a lot of these meetings will be virtual, but there's something to be said to being able to be together, and I look forward to that day. I was out there in 2009 when the University of Washington hosted the Society of Black Academic Surgeons meeting, and I got to really spend today and yesterday seeing some of the great science that continues to go on in that department. I was asked when Dr. Freischlag, Julie Freischlag, inherited me as the chair of the Department of Surgery at Hopkins from Dr. Cameron when he stepped down, and all the division chiefs were asked at a retreat to talk about your division around the framed around the question, what makes you excited about coming to work? And I'm going to use that to organize some of my thoughts, and I'll start by just describing a clinical case. I hope along the way to digress just for a second to make some points in particular to the residents, those of you that are stimulated and want to continue the great legacy that's there at the University of Washington by going into academic surgery. I hope today to become a little bit of a cheerleader for this emerging discipline of outcomes research, the ability to identify disparities based on things other than the physiologic state of our patient or the extent of the disease that we're called to treat. And so I'll start by describing a 25-year-old patient that I've seen way too many of during my career, multiple gunshot wounds, right chest, left chest, hypotensive on admission. His slight decrease in his Glasgow coma score was more related to his hypoperfusion. You see how tachycardic he is. And while he has a soft abdomen, he's got a large scrotal hematoma related to a gunshot wound there, as well as a gunshot to his thigh. He quickly gets chest tubes placed in each chest with over 1 liter returned from the right chest, over 500 cc's and counting from the left chest. A large central venous catheter is placed in his femoral vein, and type and cross sent to the blood bank. We're often running to the operating room, put him on the table with plans for a right thoracotomy, and arrival to incision was about 28 minutes. Our plan is for our GU colleagues to come and explore his scrotal gunshot wound once we address his life-threatening injuries in his chest. Our anesthesia colleague was quite meticulous in documenting the severity of his hemorrhagic shock. As you see us moving from just after 6 o'clock, that first hour or so is to an hour and 15 minutes really reflects the severity of his hemorrhagic shock with pHs as low as 7.03 and a hemoglobin that gets as low as 3. His pH is further exacerbated by the respiratory component when we had to drop his right lung in order to get hemorrhage control. The use of borrowing a GIA instrument, a gastrointestinal anastomotic device that we typically use for bowel anastomosis in the chest is one of the, I think, important advances in thoracic trauma over the last 25 or 30 years. But putting one limb of that GIA stapler through the entry wound and another through the exit wound and firing the stapler allows us to just open up the tract and then oversew those disrupted vessels and smaller airways with absorbable suture. And next lesson for the residents is you all know that what that's like, you know, a sucker, you know, controlling that area, those disrupted vessels and oversew as you see it. But that's not quite elegant if you have to write about it. So let's come up with a name. Let's call it pulmonary tractotomy for hemorrhage control. Then that sounds so much more elegant on a Friday night. But that's what we did, and it is a major advance in the sense that we no longer have to pursue a formal lobectomy or, God forbid, a pneumonectomy for exigent hemorrhage coming from the lung. There's more papers about pneumonectomies for trauma than there are survivors when you have to superimpose acute right ventricular afterload on top of the severity of hemorrhagic shock. You can see why that's such a morbid procedure and in the patients that require it. And so that's what we did. We did a right thoracotomy with pulmonary tractotomy, hemorrhage control. GU explored the scrotum and found that his left testicle was totally destroyed. And 5/6 of his right testicle had to be debrided. He received 18 units of blood, multiple units of fresh frozen plasma and platelets. And, you know, I'm kind of setting the course here. You know, certainly the trauma literature, the transplant literature, the oncology literature all speaks to the immunosuppressive effect of hemorrhage. Even if you try to control for the reasons you had to give so much blood, multivariate analysis all suggests that blood transfusion, independent of shock severity, is associated with a poor outcome. Well, I'm not going to give the august Strauss lecture to just come here and blame the patient's severity of injury and tell you about a patient that died. I'm, of course, just setting you up for the surprising outcome that we see after we start to get control. As we move into the second hour of surgery, then and only then do we start to see his bicarb starting to improve, his metabolic acidosis. We're starting to catch up in terms of his hemoglobin, and his pH is starting to rise a little bit, and it's back up to 7.3 when GU comes into the room and identifies the findings that I just described. He goes to the ICU early in the morning, next morning, and by 4 o'clock in the morning, he has normalized his acid-base status. His hemoglobin is stabilized and his pH is normal. And I just, you know, I have to tell you, you know, it's a common trick, residents, to bring some of your best cases if you're invited to give a named lecture, of course, but this one stands out in my career. For this patient to be extubated that next morning, I have to be honest, just among we friends, that was a surprise to me. I'll digress at this point to make another point to the residents, you know, find an opportunity to show some cute kid slides to get the audience on your sides. That's our son, Michael. He's 23 years old now. Something happened when he was 12 and 13. My wife and I started to shrink. And this is not his high school graduation. That's his 8th grade graduation. And I was telling Dr. Wood earlier that from age 8 to 22, he was playing Pop Warner high school football, redshirted as a freshman at Maryland, graduated Maryland last May, had another year of eligibility, and came here to Howard as a graduate student and had a great year as an all-conference tight end. But we had a rule. Why am I digressing? Well, I don't see myself as old, but I'm a little bit old school. And we had one agreement in our family, you know, he's representing the name on the back of the jersey as well as on the front of the jersey. And our agreed upon rule was, you know, for those many balls that he's caught over Pop Warner, middle school, high school, college, grad senior here at Howard, he's caught a bunch of them, but just hand the ball to the ref. Act like you've been there before. Act like you're not surprised by success. And I speak to that rule here because there's a parallel as to what I'm describing with this patient. The same rule exists in surgery. Don't get hyper excited over your success. Certainly don't let your other patients in the ICU seeing you jump for joy just because your patient didn't die. But I have to admit that we did take the team off to a side room after we saw how well this patient was doing on rounds. And we did share a few high fives jumping for joy because this patient had an outcome that really makes you start to wonder. This is the sort of case that makes me a cheerleader for what I call outcomes research. I will never, again, over the last 30 years, 360 months, taking between 4 and 8 nights a month of call, I could do that again for another 30 years, and I'll never again see a case like this. I've had a fair number of cases of patients with multiple gunshot wounds to the chest that were dead on arrival with injuries to the heart or the aorta, pulmonary artery, or other great vessels. I've had plenty of patients with gunshot wounds to the chest who were lucky to get in and out of the hospital with just a chest tube. But to have a patient who's in that middle area, 18 units of blood, potentially lethal injury, concomitant with a pattern of injury that dramatically decreases his circulating testosterone. When you look at his postoperative testosterone level, knowing the half-life, the case is made that this patient's dramatic drop in his circulating testosterone coincided with the peak physiologic insult of his hemorrhagic shock. And so only with the ability to create new knowledge from these large databases that have become available to us, prospectively created and maintained, even with a retrospective analysis, we have the opportunity to pursue in clinical surgery the question as to whether what we see in basic research is seen in humans. Now, it's been known for over 20 years that female rats subjected to experimental hemorrhagic shock do better than males. Castrated male rats subjected to experimental hemorrhagic shock do better than their non-castrated counterparts. I was the secretary of the American College of Surgeons for the same 6 years that my friend Bill Chaffee was the treasurer. And we sat next to each other several times a year during those Board of Regents meetings. And I never had the nerve to ask Bill what made him think to do that experiment where he was castrating those little mice. But the hormonal explanation for female superiority as it relates to hemorrhagic shock is fairly well established. Female rats with estradiol receptors blocked do worse than their non-receptor blocked counterparts, leading to the probably unavoidable conclusion, at least in laboratory animals, that androgens are responsible for, or at least partially responsible for the immunosuppression after trauma hemorrhage, and contrast to the female sex steroids, which are somewhat immunoprotective. And at this point, I usually say to my female colleagues, shame on you for what you're thinking. I'm not suggesting castration as a way to augment survival in critically injured patients, but I would point out that if we looked at our large registries and looked at gunshot wounds with hemorrhagic shock, let's say a subset of patients requiring 10 or more units of blood, the number used when the military was doing its research on recombinant factor 7. That's going to be a greater than 90% lesion. And so when I have an opportunity to discuss these findings, I point out that the urologists have used transient testosterone receptor blockade for decades, flutamine in patients with metastatic prostate cancer, for example. And I think it's funny, after you get a little bit of knowledge from pursuing this research, then we can speculate. Now, if we look at humans to see if there's such a pattern seen there, we have available to us the National Pediatric Trauma Registry with data from 93 centers, 50,000 patients in the first iteration, with surrogates for injury severity, both anatomic and physiologic, to identify those children with injuries severe enough to be potentially lethal. Multivariate logistic regression analyses are kind of the linchpin of this type of research, where randomization is impractical, unethical, impossible. This sort of outcomes research designed to pursue differences that might be seen in two groups that are by definition different. So in this case, critically injured boys versus girls, a multivariate logistic regression analysis, you need 50,000 patients with 92% of the charts complete with data to get to 46,000. And that's how many it takes to get down to 700 critically injured children for comparison. Now, with the average onset of menses at age 12 in this country and stratifying by pre-adolescence versus adolescence, we can see that the differences in survival, the relative 24% decreased risk of death for critically injured girls compared to their male counterparts, does not achieve statistical significance if you look at the 95% confidence interval. That suggests their relative risk of death could be anywhere from 47% less to 10% more. But it's only when we look at the adolescent group where the 62% reduced risk of death among critically injured girls is statistically significant. And so only as we get beyond adolescence, where girls and boys start to physiologically look different, do we see the female superiority as it relates to survival following critical injury. And if we look at the National Trauma Data Bank, which spans all ages, the early iteration had a little less than 1.5 million patients. 2/3 of those were male. Again, if we look at just those subset who were critically injured, about the 3% most critically injured subset, we see a similar pattern that at the extremes of age, 12 and below, 65 and above, where physiologic differences, hormonal differences between males and females are somewhat diminished, the reduced risk of death for females, again, does not achieve statistical significance. In both cases, the 95% confidence interval crosses 1. But in between those two extremes, we see the 14% reduced risk of death for females achieving statistical significance. And so I'm convinced that the basic science and clinical evidence for gender-based disparities in outcomes following major trauma is indisputable. Who? Women do worse. Why? As it relates to gender, there appears to be a physiologic, hormonal-based component. And, you know, after that, now we get to speculate and be real smart. After we generate the new knowledge, perhaps in retrospect, we should not have been surprised that from a teleologic standpoint, the survival of the species depends on female fertility, which is defined as cyclical hemorrhage. And so I think this would justify, and something that would have to be a multi-institutional trial, the trial for transient testosterone receptor blockade amongst those critically injured patients, perhaps after 10 units of blood. You're talking about a small percentage of patients, to see if we are seeing the same thing in males prospectively as we see in laboratory animals. Now, if I describe another 29-year-old male with a stab wound on a Saturday afternoon in Harlem, taken to Harlem Hospital, one might have a different image than what we see here. This is not any 29-year-old male. This is Martin Luther King Jr., who by this time had a PhD in theology from Boston University, his undergraduate degree at Morehouse, He's in September 1958, 6 years before he'll win the Nobel Peace Prize. But a deranged woman, as he signed one of his books, Stride Towards Freedom, in Bloomstein department store on a Saturday afternoon, September 20th, 1958. This woman asked if he was Dr. King. He said yes, and she plunged this letter opener right into his chest, right at the sternocondral junction, into his mediastinum. He had a little defense wound on his finger. Can you imagine? Look how sedate he looks. 29 years old, a letter opener plunged into his mediastinum, and this photo was captured. Now, this deranged woman who lived a long life, she only died a few years ago, Isola Curry, was, I don't want to be, insensitive to mental health, but she was crazy. I mean, not only did she stab him and leave the letter opener in, she then started to fiddle in her bra to pull out her gun. She tried to shoot him, but she was subdued before she had an opportunity to do further harm. And Dr. King was taken to Harlem Hospital. And after a long delay, the chief in 1958, no cell phones, and no pagers, Dr. Aubrey Maynard, the chief, who was in a movie theater that afternoon, the chief of surgical services at Harlem Hospital, was summoned. His fellows were there in the hospital, and they prepped Dr. King for surgery. The governor, Averell Harriman, came to visit him. It was September. It was an election year. His opponent in the upcoming election, Nelson Rockefeller, came in to visit him. People from Columbia University suggested to Harlem Hospital that he be transferred, and Harlem Hospital told him, no, we see quite a few of these. Dr. Maynard and those two fellows had published on a series of 81 penetrating wounds to the chest just 6 years earlier. And so they took Dr. King to the operating room under direct vision, performed a thoracotomy. The tip of the blade was literally less than an inch from the aorta. In fact, if you look closely enough, you could see pulsations of the blade as Dr. King lay there sedately. Post-operatively, there's Dr. King wondering why he needs an NG tube after a thoracotomy in the bed. And it was in the Southern Baptist style. Dr. King used the circumstance to serve as a metaphor. In Southern Baptist traditions, tell a story or a biblical passage, give your sermon, and then bring it home. And he talked about how Dr. Maynard told him that, that tip was so close to the aorta, if you had only sneezed, you might have injured the aorta and exsanguinated, or as he told Dr. King, drown in your own blood. I'm not sure I'd share that information on a post-operative visit, but that's what he told Dr. King. And that story became publicly known, and Dr. King's told of how a 9-year-old little white girl sent him a letter saying, "Dear Dr. King, I'm so glad that you didn't sneeze." And Dr. King, in one of his more famous sermons, talked about, if I had only sneezed, I wouldn't have been around in 1960. And he talked about 1 year after the other. But my perhaps most famous blend of medicine and society is this quote from Dr. King: "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Look at that statement that Dr. King made over 60 years ago, long before the term outcome disparities became sexy. Dr. King was, in essence, that statement is boiled down to its skeletal components. That's a statement about outcome disparities. So are there outcome disparities? Hopefully I've made the case about a physiologic basis, who and why, for female superiority as it relates to survival following critical injury. What about the touchier issue of socioeconomics? Can we identify socioeconomic race ethnicity-based differences? I'll tell you another story, that about President George W. Bush, who visited Johns Hopkins when I was the chief of trauma there in 2001. President Bush had a drug payment plan that he was pushing and wanted legislation along those lines. And so he decided he was going to give a speech right there in the hospital Hopkins, in the auditorium there. And the White House nursing office always travels in advance of the president's travels to make arrangements. And if God forbid something should befall the president or his family or those traveling with him. And so they decided, since the talk was going to be right there in the auditorium in the hospital, that they would use the services at Johns Hopkins Hospital, and they wanted to speak to the chief of trauma. And I gave them a little tour, showed them the emergency department, the operating rooms, and the ICU. A decision was made of which bed would be for the president, where would the press and family go. Those were the preparations that were made. And, you know, when you make such intense preparations, your mind stays fixated on it until the event is over. And when the event was over, they all said, ladies and gentlemen, please let the president depart first. And when I left the auditorium, not 3 minutes after I left on this Friday afternoon, the trauma pager went off. I was on call, and the message said gunshot wound to the flank. And again, I'll share with you my state of mind. You know, you are so committed to this event going off without a hitch that your mind can sometimes play tricks on you. Gunshot wound to the flank. And my instinctive reaction, oh no, God, don't let it be. But fear not, you know, it would have been in all the papers. It wasn't President Bush. He wasn't shot. It was a 16-year-old from East Baltimore. And he had the same surgeon, the same anesthesiologist, the same operating room and blood bank, the same ICU bed, the same ICU nurse that the president of the United States would have had he been shot that day. And that story that I've told many times between 2001 and 2008, because during those years, if you had asked me then, 19 years ago, 15 years ago, 13 years ago, are there differences based on race and insurance status to be seen in outcomes? What would you expect? I would have said no. And I would have told you this story about President Bush. The same thing, you know, we in trauma, I would have broke my arm patting ourselves in the back for trauma care. We actually demonstrate what other services pay lip service to. The president of the United States or a 16-year-old kid from East Baltimore, same treatment. No, I don't think there's any difference. And so I consider this paper one of the more impactful in my career for what I've learned participating in the study. An analysis, again, of the National Trauma Data Bank, some nearly 377,000 critically injured patients, stratified by race, ethnicity, and by insurance status. So as we go from white to black to Hispanic among the insured, and white to black to Hispanic among the uninsured from left to right, you see these progressively rising curves with a white insured patient as the frame of reference. We see, for example, that his black insured counterpart has a 20% greater risk of death compared to the white insured patient. But let me call your attention to these confidence intervals down in this row here. A black insured patient had with a 95% confidence interval has an 8 to 33% relative greater risk of death compared to his white insured counterpart. But look at the non-overlapping comparison between a black insured patient and, for example, a white uninsured patient who has a 46 to 64% greater risk of death compared to the white insured patient. In other words, this allows us, these databases, again, me being a cheerleader for outcomes research, these large prospectively maintained databases allow us to say with some rigor, some statistical rigor, that a black insured patient in this data set had a lower risk of death than a white uninsured patient. And as we tease that out in subsequent studies, I could summarize the next 4 or 5 years by telling you that no study subsequent to that particular paper, we didn't do any analysis that did not include insurance status in our multivariate logistic regression analysis. You might say, for example, well, the uninsured are more likely to have penetrating trauma. Does that account for it? Well, there's some differences, but if you do an interaction analysis comparing gunshot and stab wound patients, penetrating trauma patients who are insured versus penetrating trauma patients who are uninsured, we see a dramatically increasing risk of death. And the same is seen when we compare the blunt insured patients to blunt uninsured patients. And every analysis we do, there's nothing that is more prognostically predictive of outcomes than insurance status. Now, we frequently suggest that a study like this raises more questions than it answers. We believe if we had speculated, it's kind of fun to speculate after the fact, that insurance status is perhaps a surrogate for things like having a primary care physician, knowing your hemoglobin 1A1C, your blood pressure, your lipid profile. Health behaviors are different. We saw during the 9 years after the implementation of the Affordable Care Act in terms of filling Medicaid prescriptions. So these are the things that you bring to the table the night that you're shot or stabbed or in a motor vehicle crash. And so it raises a question of, for example, do you inherit a survival advantage when 20 million Americans moved from the ranks of the uninsured to the insured? It was at the time that we pursued a grant with the National Institute for Minority Health and Disparities. The projection was that 30 million Americans would move from the ranks of the uninsured to the insured. Do you, for example, if you go most of your life underinsured or uninsured and you get to age 65 and become Medicare eligible, is that the same? Do you suddenly inherit that survival, or is it different from someone that's gone most of their years with the job that provides insurance? These are the things that we are interested in pursuing. And so when you start talking about healthcare access, insurance status, race, particularly as it relates to trauma, we have not only a responsibility to have rigor in the science, but a willingness to discuss uncomfortable conclusions or disruptive solutions. And I'll close by sharing with 3 final slides that demonstrates what I'm talking about. We don't frequently do actuarial survival curves in trauma. Our oncology colleagues, medical and surgical oncologists, do that far more frequently than we do. They will talk about a 2-year actual survival curve following pancreatic cancer, or a 5-year curve following colon cancer, or a 10-year curve following breast cancer. But this is such a curve that goes out to 14 days. You know, we have lower attention spans in trauma and critical care. And so if we look at the same National Trauma Data Bank and look at when patients are dying, going out to 14 days, we see a modest but significant difference in the survival rate of whites versus minorities, blacks and Hispanics. Whites do better, but the difference is seen at that first day. And the curve is fairly parallel as you go out to 14 days. If, for example, we look at gender, women do better, we've said that. We see that difference on the first day, and the differences become slightly more disparate as we go out to 14 days. As I said, insurance status trumps race, gender, mechanism, blunt trauma, penetrating trauma, as the strongest association predicting death among critically injured patients. The last of these 3 slides that I'll show you is what I call the most uncomfortable slide that I show in any talk that I give, comparing insured patients with uninsured patients. A dramatic disparity in death rate between the insured and the uninsured that we see on the first day, again suggesting some pre-hospital etiology. But the fact that that disparity grows so disparate continuously throughout the 14 days of hospital care is something that is uncomfortable to me and should be to all of us. I've given some portions of this talk to lay publics. I spoke at the Congressional Black Caucus, and a staffer, congressional staffer, not a scientist, said to me, well, Doc, what's happening during those 14 days? What's happening in the hospital? Are they being treated differently? You know, that was a tough question. It was a fair question, but a very tough question, which again is another question that's raised by these studies. And so to take all of that in, I would suggest that our next step is to take advantage of the fact that state registries have matured to the point that we are able to, based on demographics, mechanism, pattern of injury, anatomic and physiologic surrogates of injury survival, we are able to estimate a risk of death. And we are able to evaluate a trauma system or a trauma center by comparing the observed versus the expected rate of death. And now that we have first 17 and now 13 states that did not accept the Medicaid eligibility expansion, it's now 140% of the poverty level that was provided for in the Affordable Care Act, we have the ability to compare, say, a state such as Kentucky that accepted that Medicaid expansion and went from 18% uninsured to about 6 or 7%, and compare it to a demographically similar state such as Georgia, which did not accept it and still went from 18 to 17%. And by comparing O to E ratios before and after, say, the 2010 passage and 2011 implementation of the Affordable Care Act, we can pursue one of our hypotheses that perhaps, we used to use the term, I stopped using it, herd immunity. It's got a bad name now. But if you insure 94% of patients in a state, does the overall health status of the state improve? Such as the scene if you immunize 85 or 90% of 6-year-olds in a class against chickenpox, for example. But comparing a state like Kentucky pre and post Affordable Care Act to itself and then comparing it to another state such as Georgia would help us address this issue about insurance status, because I'm sure no one would be surprised if I told you our Outcomes Research Center demonstrates insurance-based outcome differences across a host of surgical diseases: cardiac surgery, vascular, transplant, bariatric surgery, surgical oncology. But the difference between those and injury, and we make the argument that injury stands alone as a disease where critically injured, uninsured patients gain access to the system every bit as quickly as their critically injured, insured counterpart. We cannot use access as the explanation for what we're seeing. There is something, we call it the Protoplasm Theory. There's something about these insured patients, and perhaps it is a Protoplasm Theory, that we think injury is the ideal area where this should be pursued. And then if we did find that, in fact, something about their insurance status made them more able to withstand the rigors of critical trauma, what about the race-based component of it? A white insured patient versus a black insured patient. We still see differences. How would we pursue that? Well, we suggest if there was a database that had a diverse number of fairly diverse sampling of patients by race and ethnicity, and they had a monolithic lifestyle, and they all had access to healthcare. Indeed, let's say they had a mandatory healthcare, and yet despite all those positive features of a lifestyle that might predict survival and a healthy protoplasm, they are at risk to sustain major injury. And of course, that database would be the military database. We treat those heroes with fairly stabilized treatment protocols. They have a mandate. If they have too many comorbidities, they're not eligible to be in that area. And so and in fact, in the military database, some of the non-traumatic acute care surgical outcome disparities are diminished. And so I've always said to our residents and students that are interested in these type of research, a project that is most attractive would be that one where no matter what your finding is, set your bias aside. Yes or no, do race-based differences persist in the military database? If they disappear, then while our civilian hospitals will never have everything that the military bases do in the arena, we certainly would be able to identify what the business professionals call best practices. And if race-based differences persist, even in that database, we have just the fertile ground for more studies, because this social construct to have these persistent differences is something that should attract many researchers to seek that answer. And so I would close by suggesting that the basic science and clinical evidence for gender-based disparities and outcomes following major trauma is indisputable. Who? Women do better. Why? It seems to be a hormonal basis. If you look at the experience of experimental hemorrhagic shock in hormonally manipulated lab animals. And when we pursue the socioeconomics, the fact that we see insurance-based differences on the first day of care that become more disparate throughout suggests to me that trauma would be the fertile ground to really understand every aspect about insurance that helps our patients pursue their most optimal outcome. And that's what I am dedicated to pursue over these next coming years. So ladies and gentlemen, that's what I like about coming to work. And with that, I thank you for the distinct honor of being able to give the Strauss lecture. And I look forward to any questions that you have. Thank you.
Dr. Cornwell, that was fantastic. And I know we're going to have some questions. I'm going to start out, though, because I have the benefit of being the moderator. You've made this very strong point about insurance status. And you've also used some of the military comparisons. I'm wondering about international comparisons. So let's take a country like the UK with nationalized health insurance and with very good research on quintiles of deprivation. So do we have any similar data from the UK about trauma, in this case, in a nationalized health system where everybody has the same insurance,
right,
but with variations of obviously socioeconomic status to know how much of this is driven by the deprivation score versus the actual insurance?
Yeah, so sure, I don't. Obviously, we don't have insurance differences. We do know, and you touched on it, throughout this literature, when we look at over there as well as over here, household income, we mostly by quartiles in our group, there are certainly differences by household income. There's differences by household education. So I think here insurance status is just a strong surrogate of that. But I don't know of information regarding quintiles of household income amongst a European population where everyone is insured. That's a great opportunity for interaction analysis, insurance versus household income in a group that's completely insured.
And let me ask one other question, because you've made, I think, a very good point that in our system, trauma patients get access to care because of our good emergency systems. But I'm wondering about the access to care in the 3rd hour or the 12th hour or the 2nd day, that is transfer potential to a higher level of care, and whether that happens as readily in patients that are not insured or underinsured.
It happens. It's not supposed to happen. As EMTALA says, it's not supposed to happen, the so-called wallet biopsy. But it does happen. There's evidence of that. And let me take your question even farther out upon discharge, because certain injuries, I had the slides, but time prevented me from showing it. Certain injuries, such as traumatic brain injuries, we don't prognosticate that outcome, life, death, and even functional abilities until we get out to 6 months or more, because it's affected by your access to rehab, the social network, family support. And so let me add to the answer by giving you 2 examples of papers presented at the AAST, the American Association for Surgery and Trauma. In fact, can I share my screen? Can I share my screen just to show you a couple of slides? Let me just real quickly.
And now the questions are coming, Dr. Cornwell. I've got a couple.
Okay.
Pretty prominent surgeons that I'm going to direct questions from.
Okay, I just want to quickly show, this is a study that my colleague Otto Hader presented at the AAST in New Orleans about Black children experiencing worse. And this is an example I call on when I say the science has to be good, because the session was running a little late. Dr. L.D. Britt was moderating it. You know the taskmaster L.D. is. And so there's only time for the discussant, primary discussant, and two others. And there was one of our colleagues who was at the mic when Dr. Britt shut it down, saying, we have to get to the poster session. And he stood at the mic and he said, that's bull, BS, he said that. And then he walked and got a little histrionic to my then fellow up at the podium. And if you listen, the tone was a little unprofessional, Dr. Woods. And so I rescued my fellow and said, my colleague, I've been a member of this meeting for over 20 years. I've disagreed with a lot, that I never yelled, that's bull. And the point is, after discharge, these Black children had a worse functional outcome in terms of locomotion, independent feeding after critical brain injury. And when the paper was published in Journal of Trauma, they published it with an editorial from that colleague and our opportunity to respond. All of that in the same journal. The paper, the letter to the editor, and our restraint, all in the same journal. And our colleague says he found the paper to be troublesome after it was presented to AAST without time allowed for discussion, without discussion due to time constraints. Their conclusions could have unintended consequences and are an insult to those who take care of injured children. He missed that this logistic multivariate regression analysis, the linchpin of outcomes research, by definition takes into account the things that he said explained it. So our group decided, let's let the brother respond. And so I wrote, we understand the discomfort such a study creates, perhaps no topic in American dialogue. This was 10 plus years ago. I could have said it 15 plus years ago. I could have said it this year, couldn't I? Generates as much emotion as race. Our own study group is racially, ethnically, religiously diverse collection of investigators, all who have spent our entire careers at urban trauma centers caring for predominantly minority patients. We feel personally challenged by the results of this study, but are no less convinced of its validity. Thou doth protest too much. Why does he have a right to be upset and not us? We all are upset by it. But my point is that, yes, we have problems. And this year's AAST showed from the Pennsylvania registry improvement with insurance status in patients on gaining access to rehab following discharge. It changed the pattern and the destination for rehab. Let me stop sharing. For rehab. So I think we certainly know we see differences coming in, differences throughout hospitalization, differences transferred in, and differences on the ultimate destination by insurance status. It's powerful, and it's not just explained by access coming in. I mean, I should tell that President Bush story for years until that paper was, oh, there's no differences, there's no differences. How wrong I was.
Well, and I think it follows the quote that you gave from Martin Luther King about the injustice in healthcare right at the beginning of your talk.
Right, right.
So the next question is first a compliment from Dr. Pellegrini. You know him, right?
Absolutely. Our host in 2009.
Yeah, he's
honorary SFAS brother. Yes, absolutely.
Yeah, wonderful talk. Would you care to elaborate on what would be the impact of a Supreme Court decision to eliminate the Affordable Care Act on outcomes of trauma victims?
Yeah, it's a great question.
Just throwing out a little political fire there.
Yeah, no, it's a great question. Our grant to NIMH was reviewed on the day that the House repealed Obamacare, and as we all know, the Senate did not pass that by one John McCain thumbs up, thumbs down vote. I think the implication is that for reasons that we don't completely understand. Clearly, the overall response, the overall risk is going to be worse, but even in trauma care. And remember what state benefited most statistically of the 37 states that accepted the Medicaid expansion, the state of Kentucky, the home of the Senate Majority Leader that is leading that charge to repeal it. So I'm worried. As I mentioned earlier, my 23-year-old son is worried because 26-year-olds can still be on their parents' insurance. So I think I saw him out picketing too. So we all have, but certainly the Medicaid expansion was the single biggest explanation for increasing the ranks of the insured. And my dear friend, Dr. Pellegrini, asked a very perceptive question, of course, as usual.
Yeah, he's hitting about three touchy points all at once, which of course, Dr. Pellegrini is good at doing.
That's right.
The next question is from Mika Sinanan, another person I think that you know well. And this touches on, I think, some of what you were talking about towards the end, the military being a equal access system. And Mika's asking, are there differences in outcome by race for soldiers that are injured?
We want to study it. Mallory Williams, my colleague, a colonel who's back from his last deployment, the first database that we asked them for access to, actually, can you believe it, didn't have, they may or may not have had it, didn't have availability to us by race. But we want to study it. I think that is the place to study. I mean, they're all heroes to us largely. They're all treated with protocol-based care largely. They all have a monolithic lifestyle. They mandate you have to have healthcare access. I mean, I think it's as good an example that cries for studying as there is. So I don't know. I want to know before I retire.
Well, Dr. Cornwell, it's 8 o'clock where you are. You can tell your dean that the visiting lecture that you gave, that the dean stuck it through to the end. And it was 8 o'clock. So first, I want to thank you, Dr. Cornwell, for being here as our Alfred A. Strauss 71st visiting lecturer. It's been a privilege to have you with us yesterday and today. You stuck with us all day during the Harkins Symposium. A great presentation by our faculty, and particularly from the Division of Trauma, Burn, Critical Care. So thank you for that. I also want to thank Dr. Ramsey for joining us for this important lecture.
Thank you, Dean. Thank you, Dean. Appreciate that.
I want to thank Dr. John Strauss and Mr. John Friedlander for representing the Strauss family and being here, loyal and our friends as always. And finally, big thanks to Ellison Fiddler and Savannah Tam, who were the brains and the brawn behind putting all of this together. So thank you all for a great afternoon. Thank you, Dr. Cornwell. And I wish everyone a good weekend.
Thank you. Appreciate it. Wonderful. Thanks so much.